Chapter 22, Part 1, talking about psychiatric emergencies. You will run numerous calls that will be the result of psychiatric emergencies or a behavioral crisis. And they may be related to a diagnosis of some type of mental illness, or they may just be anxiety or stress-driven issues that arise for your patient. You do have to be cautious in these calls because they will present the potential for safety issues that may arise during the call. And you also have to keep an open mind, as with many things that you will run and many calls that you will participate in. You've got to not be judgmental about what is happening and how your patient is handling whatever it is that is going on. One of the most common misperceptions is that depression, feeling bad is just a sickness. But in reality, there's a lot of things that can happen that can lead to a person feeling depressed. A lot of issues that arise in a person's life that can become problematic and hard to deal with. You have to recognize that not all patients who have mental health disorders are going to be a danger to others or themselves. But because of the nature of what we do, we have a higher probability of running into those patients, of seeing those patients and running the calls with those people who are in a mental crisis that is leading to an increased chance of physical harm being done. In these calls, communication will be key. Staying in touch and communicating with the patient and with the receiving hospital and with others on the scene are going to be your priority. You have to understand when dealing with behavioral crises and that the level of crises, that what defines a crisis is going to be dependent on the person. So normal behavior is based on what is normal for that individual, not necessarily what is normal for society, because what is normal for you in terms of behavior may not be what is normal for me in terms of behavior. And so we have to find out what is the normal for our patient and start, making judgments based on that. Sometimes we can adapt to the stress in our lives, and sometimes it gets to a point where we just can no longer handle it and cope with what we're dealing with. The acute stress reactions are the ones that we are probably going to end up seeing. So what is the trigger? What has caused them to reach that level where it's just not, they're not capable of dealing with it anymore. The crises is when the level of behavior is no longer acceptable for the people that are around the patient. Something has changed to the point that we now see our patient outside of what is tolerable and what we are able to handle, and that's what happens. That's when we end up responding, is when someone in this individual's life, and it may have been the person themselves, has decided that they can no longer handle what is going on. A patient who has dementia or depression, who is in a behavioral crisis, is looking at behavior that is going to change their ability to do the activities of daily living. So, again, what is it that puts them above and beyond at that higher level of dysfunction? And then there are people who have chronic depression, who are, have learned to deal with the daily life while also dealing with the mental health crisis that they face on a daily basis. We need to recognize that abnormal behavior patterns of greater than a month are definitely a concern. And it may not be that it is a level where we would consider it a crisis. It may just be that because of the length of time they've been dealing with these issues, now it's become problematic and concerning. When an emergency arises, you may find patients who are presenting with violent tendencies or are a threat to themselves or others. So we definitely have to use caution when approaching the scene, but not every psychological crisis is a violent offender. These are not always going to be somebody who is going to become a danger to you or your crew or even to themselves. But you do want to be prepared just in case that happens. Mental disorders do affect tens of thousands of people across the United States. So you will run across a large number of people who probably have been diagnosed as having a mental disorder, but they don't have to have a history for a behavioral crisis to occur. Anxiety is one of the most common mental health disorders that people will be diagnosed with. Some of it is incident specific, where the anxiety occurs in a specific area, so in crowds, when they have to give speeches before tests, and some of it may just be general anxiety. So you've got general anxiety disorders, just a general sense of worry, fear, etc. Panic disorders, social and other phobias, so those people who are afraid of going out in public or being in crowded spaces. Patients who suffer from post-traumatic stress disorder, and then obsessive compulsive disorder. All of those fall under the anxiety heading. We do have levels of assistance that are available, but unfortunately, we are seeing an increase in the number of people who require mental health assistance and a decrease in the number of resources that are available. Most disorders are going to be handled by a psychologist. That is, talk therapy. There's some interventions, but most of the prescriptions, your high-level prescriptions for severe psychological disorders are handled by psychiatrists. And then, of course, there are also counselors, so they help talk, they help help people look at things in a different light, maybe with a different perspective. Most people handle their psychological issues with outpatient visits, going to an office 1, 2, 3 times a week. And then when they reach that level of crises, you then find that they get admitted to specialized psychiatric facilities, whether it's a unit in a hospital or a standalone building. You have to keep in mind that psychological crises, mental health and behavioral issues aren't necessarily just because someone's crazy. There can be many underlying causes associated with it that have triggered these issues. Disease. Some of them are a disease. Schizophrenia is considered a disease. Some of the behavioral crises come on because of tumors, strokes, stress, situational stress, social anxiety stress. And then some occur because dehydration, electrolyte imbalance, again, tissue death as the result of stroke or hemorrhage. Long-term brain damage due to drug use is also an issue that you will see and causes psychological disorders. We don't diagnose our patients. It's not my job to see them at this call and go, oh, this person's schizophrenic. That's not what you do. But you do, of course, need to understand that the physician is going to look at them in terms of organic and functional diagnoses. Our organic disorders are temporary or permanent due to the result of a physical or physiologic function of the brain tissue. So changes in the physical structure or in the physiologic function of the brain. These are those behavioral health issues that occur because of a traumatic brain injury, seizures, stroke, tumors that require removal of brain tissue, drugs and alcohol abuse that alter the functionality of the brain. Those are going to fall under organic issues. So when someone talks about they've got a family member who received a traumatic brain injury during war and it really changed their behavior, you're looking at an organic disorder under psychological emergencies. Other ways, hypoxia, hyperthermia or hypothermia, hypoglycemia, all of these. And of course, occasionally you can reverse some of these. If you treat a hypoxic patient or a hypoglycemic patient in a timely manner, then you can reverse the effects and maybe not see long-term issues. Functional disorders, they cause problems in the brain that impair the ability to function appropriately. So the brain tissue will not conduct the jobs that it's supposed to. So you've got schizophrenics, anxiety conditions, depression. They actually alter the physical functioning of the brain without necessarily altering the appearance of the patient. So they're not sending the messages, they're not firing the neurons the way that they should. There may be an overfiring or an underfiring that causes issues. We can, as an EMTB, as a regular person, respond to a psychological emergency and provide appropriate care in a safe manner. We've got to put scene safety and our safety first, and we've got to always be cognizant that this could become an issue. But otherwise, good practice and good communication skills are sometimes the best and only thing that you need in these situations. You've got to assess the scene. You've got to understand where are the entrances and the exits. What does the scene look like? Have they destroyed it by being violent and throwing things around? Do you see any weapons that might become weapons of opportunity for your patient? Those types of questions. Make sure you've got appropriate PPE. Communicate and talk to your patient at all times. What are you doing? Know what you're doing. Stay calm so you can de-escalate your patient, so you can keep them calm. If you start to act agitated, it can negatively impact your patient. And again, talk to your patient. Identify who you are and why you're there. Don't lie. This may take more time than you were prepared to spend on this call. Ask before you touch the patient if you can. Don't get into a back and forth argument. Don't try to prove them wrong or tell them that you're right and they're wrong and they have to listen to you. Again, your goal is to keep them calm, provide them feedback and information, and get them the help that they need in a timely manner. Again, what's that scene size up? Do we need to stage? One of the things to keep in mind is that if this came out as a psychological emergency, if this came out as an attempted suicide or a patient who's threatening to harm themselves or others, you shouldn't be entering the scene without law enforcement. If law enforcement has been dispatched with you for scene protection, you need to make sure law enforcement is there to provide scene protection. Does the behavior seem normal? If they're telling you that their dad just died, their husband just died, etc., and they're distraught, that's kind of normal. And then consider whether there are legal issues involved. Are they able to make decisions for themselves? Is this someone who also has some legal issues going on that you will be impacted by in your ability to treat or transport them? Are they capable of giving consent or of refusing treatment? Take the standard precautions and request that additional resource as necessary. Do you need law enforcement? Did the scene start safe, but now it feels unsafe and you'd like that law enforcement for assistance? Go ahead and get them called. Do you need to consider ALS for potential chemical assistance? If so, get that phone call going. Is this a psychological emergency, or is this a physical trauma that is maybe being made worse because this patient has behavioral issues? Determine whether there is a nature of illness or whether there is a mechanism of injury associated with this. Note in the scene whether there are drugs, alcohol, anything that might make the behavior of this patient worse or better. As you approach the scene, start thinking about how this patient appears. What is their mannerism? Do they appear to be agitated? Are they pacing? Again, was the scene disturbed because they've been throwing things around? Or do they seem fairly calm and approachable and not quite such a danger at this point? And start talking to your patient immediately. Who you are, why you're there, what your goal is. I'm here to help. I'm here to get you some assistance. I'm here to give you what you need. Whatever it is, talk to them, ask them questions, and get them interacting with you. You may not get a chance to necessarily get directly up close with the patient, especially if they're being erratic or moving around a lot, but you should be able to tell even from the doorway, if they're talking to you, that they've got a patent airway. Do you hear noisy respirations? How does their breathing effort appear? Those types of things. If they're going to let you touch them and assess them, consider pulse oximetry to determine if hypoxia is an issue. Check a pulse. Again, if they're talking to you and moving around, they should have a pulse. I've not seen anybody up and talking and moving around that didn't have a pulse. But if they're not going to let you touch them, then you have to do these assessments from a distance as best possible. Look at the skin color, temperature, and condition. Are they agitated and flushed? Are they shocky? What are you seeing? Have they injured themselves and harmed themselves and have a bleed that you need to try to control? All of these are issues that you need to be checking on, regardless of whether they are moving around or if they're letting you sit down with them and assess them. Unless they're unstable, unless this is a patient who maybe has suffered a medical emergency or who has suffered any type of physical trauma that is going to be life-threatening, you need to be prepared to take your time. A psychological emergency itself, without any type of self-harm, isn't a load and go or high priority. So, be prepared to take some time, be prepared to spend some time with your patient to get to know them better and figure out what they need and get them to trust you. But for the most part, again, psychological emergencies are not load and go patients. This is where you're once your primary is done, now you're getting into the part where you need to start talking to your patient even more so. This is where you're going to get to know them and where you are going to determine maybe what the history is, or if there is no history, what it is that has caused this patient to change their behavior so significantly that someone felt 911 needed to be called. You need to try to figure out, is there a problem with the central nervous system? Are they moving? Are we looking at this as a organic issue or this is a functional issue? Have they taken anything that might have caused additional problems, such as drugs or alcohol? Or have there been any life changes that are leading to the potential of this behavior change? Find out whether they have a history, whether if they don't have a history, you might want to ask, do you have any family history? Consider whether especially if this is a patient who is of an appropriate age, whether Alzheimer's or dementia may be the cause of this behavior change. So in sample, your goal is to look for those major life threats while also trying to keep them calm and minimizing the stress of the situation. Here are some questions. So table 22-2 in your book has some questions that maybe you can use to find out some information, to kind of evaluate what type of behavioral emergency this really is. What are their vocabulary and expressions? Are they expressing disordered thoughts or delusions or hallucinations? Those types of things. Try to conduct a physical exam to make sure there is not a physical cause for this. Make sure that they haven't hit their head and don't have some type of traumatic brain injury that you're dealing with. But also recognize that even if they are conscious and interactive, when you ask questions, they may not answer them. Use caution when interviewing others, especially in the presence of the patient. So try not to interview a family member because that could actually cause some additional agitation, at least in front of the patient. If you want to interview a family member, consider stepping into another room to talk to them. Look at their facial expressions, take their vital signs if you can, and this will give you a big idea about how they're doing. Is their heart racing? How's it going for this patient? And again, are their eyes looking at you? Are their eyes darting around? Are they kind of in that 500-yard stare? That can kind of give you that understanding of where they are as in their mental health functioning. And make a transport decision. So one of the decisions in a behavioral health crisis that may have to be made is, are they going with you or are they going with law enforcement? And while we don't want to play good guy, bad guy, really when someone is a threat to themselves, they are going to go with law enforcement because the goal is law enforcement, once they're in custody, can make the medical decisions for them. And that normally involves saying, yes, this patient needs additional assistance. When you transport your patient, if they're in law enforcement custody, then law enforcement should transport with you, especially if they have handcuffs on. If you're afraid that a patient may become a danger to themselves or to you during transport, get law enforcement to ride with you. Otherwise, if you're just transporting a patient who is having a behavioral health emergency that is not a threat to themselves or to you, then put them in their position of comfort, give them some oxygen if they'll tolerate it, and transport them to an appropriate facility. Never let your guard down with these patients. Just because they appear to be non-harmful to themselves or to you doesn't mean that they won't become so later. So definitely ensure that you are kind of standing your guard and reassessing the scene, which has now moved from wherever the call was to the ambulance, the entire way to the hospital. Also, if this is a patient that you have had to restrain because they are presenting as a danger or they became combative, then go ahead and assess them every 5 minutes to make sure that their airway is patent and that there's no breathing difficulties due to the restraint. Check your interventions, but in reality for the psychological emergencies, there's very little you'll do for this patient. As I said, if they'll take oxygen and tolerate it, there's no harm being done there. But more than likely, this is just a patient you're going to transport to the hospital in a position of comfort. Now, if they are restrained and they're still trying to spit or bite you if you're anywhere near them, then an oxygen mask is actually a really good thing because it will protect you and them. We have definitely got to make sure we are giving the hospital fair warning of these patients so that they can prepare to receive them, and also so that they can prepare if this is a patient who is combative or it's a patient who is restrained, so that they can be prepared to do whatever it is they feel is necessary. If your patient is restrained, make sure they know how you have restrained them so that they are aware and prepared to make that transfer safely and in an appropriate manner.